So we're going to continue with the NYU presentations, with the NYU program, with Stephen Ross, who's one of the three co-principal investigators and head of the project, and Gabby Agin Liebes, who's been working there and has now branched off and is doing some very interesting work. I'll read you their bios. They're going to tag team, and I'll read you them both up front. Stephen Ross, MD, is an associate professor of psychiatry and child and adolescent psychiatry at NYU University School of Medicine, an associate professor of oral and maxillofacial pathology, radiology, and medicine at the NYU School of Dentistry. I warn you, by the way, this is one of those people who does 16 incredibly important things all at once. We could not cut his bio. He directs the Division of Alcoholism and Drug Abuse and the Opioid Overdose Prevention Program at Bellevue Hospital Center in New York City. He's Director of Addiction Psychiatry at NYU Tisch Hospital and Director of the NYU Addiction Psychiatry Fellowship. He's certified in general and addiction psychiatry by the American Board of Psychiatry and Neurology and in addiction medicine by the American Society of Addiction Medicine. Dr. Ross has received a dozen local and national teaching awards related to education of medical students, psychiatry residents, and postgraduate fellows. Dr. Ross is an expert on the therapeutic application of serotonergic hallucinogens to treat psychiatric and addictive spectrum illnesses. He directs the NYU Psychedelic Research Program and is principal investigator of the NYU Psilocybin Cancer Project. Dr. Ross received his research funding from the National Institute on Drug Abuse and the Hefter Research Institute. And Gabrielle, who will be presenting with him, Gabby, is completing her training toward a PhD in clinical psychology at Palo Alto University, examining the effects of self-compassion on trauma-related guilt cognitions and shame. Through the University of California in San Francisco, Gabrielle is co-leading a qualitative investigation of a pilot study examining the safety and feasibility of psilocybin-assisted supportive expressive group psychotherapy for demoralization and existential distress in long-term AIDS survivors. Prior to beginning her graduate studies, Gabrielle served as project manager of the NYU School of Medicine Psychedelic Research Laboratory led by Dr. Ross in the Department of Psychiatry. Gabrielle's research interests include the role of self-compassion in addiction recovery and the therapeutic applications of loving-kindness meditation and compassion-based mindfulness. Just a wonderful combination of speakers. I welcome them both up to the stage right now. Steve Ross and Gabby Agin Liebes, please. NYU.
What? Yeah, that's fine. Yeah. Okay, great. It's a real pleasure to be here today. So I'm going to mostly today tell you about the results of a 10-year trial. It took a decade to complete our randomized controlled trial using psilocybin-assisted psychotherapy to treat cancer-related psychological and existential distress. I'm also going to talk about the future of that project, and I'm also going to mention a little bit of other things that we're doing at NYU in terms of our psychedelic research group. And Gabby is going to present the results of our qualitative trial. In terms of disclosures, I received research funding from NIDA, NYU Langone, Hefter, Janssen Pharmaceuticals, and now MAPS and the USONA Research Institute. So I'm very briefly going to talk today about death and dying in America, where it happens, where it should happen. I'm going to define cancer-related distress in terms of its epidemiology and its relation to adverse outcomes and treatment outcomes. And then I'm going to mention cancer-related existential distress, define it, and talk about the outcomes related to it as well. I'm going to very briefly talk about the history of the use of LSD-assisted psychotherapy to help the dying. And then I'm going to talk about the modern era, really a collaboration between UCLA, our group at NYU, and Johns Hopkins. I'll tell you about the design of our trial, our results, and then we'll talk about the future. So in terms of where people want to die, you can think about where you would want to die. Most people do not want to die in an ICU, but unfortunately in the United States, that is where the majority of people die. The human encounter with death in the United States has been assigned to medicine, but medicine has done a poor job of helping individuals just because we're not trained. I received very little training to help the dying as a medical student. The best training I got when I was 12, my mom was a hospice worker and took me to a hospice, and there I saw what a good death was like, but when I did my oncology rotation, it was more chemo up until the very end. So we do a poor job of facilitating the dying process in the United States. So most people die in hospitals. Most don't want to die there. They say they would prefer at home. So this is what a bad death looks like in the United States. And when people get sick with medical illness, they cite existential spiritual themes more and more. But again, the problem is doctors are not trained, and these are the kinds of things they want, especially towards the end of life: meaning, purpose, hope, etc. So in terms of a good death, there's a bunch of constructs that go into it. It's important to make clear decisions, review one's life. We do that in our trial to be able to contribute to others. Spirituality keeps coming up again and again. And feeling not stuck. The patients in our trial, I'll get to, really felt stuck and felt that life had no meaning anymore. They wish that they could be dead. Cancer is a really frightening thing. To be diagnosed with cancer is really horrible. It's incredibly common. Close to 1 in 2 over the course of our lives will be diagnosed with cancer. Everyone will get cancer eventually because the genetics of our cells break down. But it's very common. In addition to that, distress associated with cancer is highly common as well. Depressive spectrum disorders, anxiety spectrum disorders. As many as 40% of hospitalized patients will have some psychiatric-related phenomena, and as many as 1 in 2 towards the end of their life will have problems. And when anxiety and depression are present in cancer patients, it has a whole host of negative outcomes, including decreased survivability from the cancer, probably related to the link between psychoneuroimmunology and impaired immune function. In addition to that, these types of adverse states, anxiety and depression, can predict a hastened desire to want to die and ultimately completed suicide. And the treatments for anxiety and depression in cancer are really not that great. The medications tend to not do well. There are 3 meta-analyses done in the last several years, and essentially they show within cancer, antidepressants tend to work no better than placebo. In one of these meta-analyses, they looked at other medical disorders like AIDS and post-stroke, and their antidepressants did do better than placebo. So there's something about cancer where antidepressants tend to not do that well. The psychotherapies tend to not do that well as well. I want you to remember the 40% placebo response, and we'll compare that to what we found in our trial. So there's a big spectrum of response in terms of when someone is diagnosed with cancer. Some cope through denial, some cope through meaning. They say, this is sort of the best thing that's ever happened to me. It's allowed me to really focus on what's important in life and not focus on things that are not important. But then there's those that experience existential distress. And this has been described by psycho-oncology for about 3 decades, but it's feeling powerless, a sense of futility, meaninglessness in life, hopelessness, loss of dignity, feeling isolated, disconnected from one's family, from one's spiritual practice, a sense of disorganization, and a sense that I wish I just could be dead already, which is a really frightening thing to experience. And existential spiritual distress, when it occurs, similar to anxiety and depression, has a host of negative outcomes associated with it, including decreased quality of life, increased healthcare visits, and again, increased hastened desire to want to die, and increased rates of suicidality. And cancer patients are at 2-fold risk of completed suicide compared to the general population. And upwards of a quarter will have this phenomena of, I just wish that life could be over already. This model here, let's see if I can use this pointer here. I want you to focus on depression and hopelessness and spiritual well-being. We were able to affect all 3 of these constructs. I think Matt Johnson presented earlier the data, population-based data, about the use of the psychedelics and suicidality. I'm going to come back to that, because even though no one studied psychedelics as an acute anti-suicidal agent, I think there's good evidence to suggest that it may work for that. And when you can improve spiritual well-being, you can improve quality of life, decrease depression. A lot of those constructs can improve when you can improve the spiritual existential domain of distress. And throughout medicine, there have been calls now to really focus on that domain of illness, even though doctors are not used to thinking about it. And the 2 prototypes where spiritual distress has long been part of medicine is addiction and end-of-life related distress. There are no pharmacotherapies that deal with the existential domain of illness. There's some psychosocial treatments that have been developed all the way back to Jean-Paul Sartre, Viktor Frankl, up into the modern era. There's a group of psychiatrists and psychologists that have attempted to manualize existentially oriented psychotherapies, and there's some evidence base. We used a lot of these therapies to create the psychotherapeutic platform for our trial. So you guys have probably heard a lot about this, a very brief history of psychedelics in medicine. Psychedelics have been used as plant compounds in cultures for thousands of years. But Albert Hofmann accidentally discovered LSD in 1943, and it started this huge part of psychiatry, which I learned absolutely nothing about until Jeff Gus in 2006 kind of clued me into it. But I couldn't believe that this enormous part of psychiatry, over 40,000 research participants, over 1,000 studies, was completely buried and suppressed by the war on drugs in 1970, a war that essentially has hurt minority individuals that have this neurologic problem called addiction. But it is amazing to me, this was such a big part of psychiatry and it was completely suppressed, only to be brought back by Rick Strassman, University of Mexico, and then a group of individuals, UCLA, Johns Hopkins, University of Arizona, NYU, and then New Mexico, again, and University of Alabama. So the first individual actually to talk about using psychedelics to help the dying, this is Valentina Wasson, Gordon Wasson's wife. She was a pediatrician, and the first recorded literature of anyone thinking that a psychedelic could help the dying was her. Aldous Huxley, on his deathbed, Laura Huxley injected him 100 mics of LSD. But really, the research done with hallucinogens to treat the dying were these two people. It was Eric Kast and Stan Grof. And Eric Kast really was amazing. Who here has heard of Eric Kast? Yeah, so this guy was incredible. He was both an internist and a psychiatrist at the University of Chicago. He knew nothing about LSD, but he ordered some in the 50s because you were easily able to get it. And he dealt with patients who were dying from cancer and had horrible refractory pain syndromes. So this is before understanding the methodology of using them by Stan Grof and others. And he would come by in the morning and he would ask their patients to stick out their tongue. He would drop 100 micrograms of LSD on their tongue and just sort of see them at the end of the day, which is kind of like crazy if you think about it, and just like unthinkable. But he was so beloved that his patients did really well. He did this hundreds of times. And what he found, he actually did a control trial of LSD versus an opiate and found that the LSD group had an anti-pain effect that was beyond the acute phase, upwards of a couple weeks. But in addition to that, he also noticed decreased mood, decreased anxiety, and decreased fear of death. And he went on to do this open label in hundreds of patients and kept finding the same thing, that there was something going on, that they were accepting of the death process and felt less anxious and depressed. And this sort of set the stage for what happened with Stan Grof at Spring Grove. And the kind of dream team of psychedelic research sort of descended on Spring Grove. It was a collaboration between Johns Hopkins and University of Maryland. It was led by Stan Grof. And here they were actually started to work with addiction, but one of the nurses developed cancer, and they really switched over to a cancer protocol. And this is really the model that we all used in the modern era. They had 60 terminally ill cancer patients. This was open label research. It was mostly females versus men. They included people that have anxiety and depression. These were people towards the end of life. What I love about this trial, it was mostly African-American minorities from Baltimore that were included. It was the only psychedelic study ever that included predominantly minority individuals, and that's something that we're working hard at Bellevue to bring back. The trial that we did took place at the Dental College and did not include Bellevue for various reasons, but we now have been able to relocate our laboratory back to Bellevue Hospital to be able to work on a patient population that's most dear to me. The exclusion criteria are very similar to what we've done in the modern era. It's important to rule out major psychiatric illness. It's important to rule out people that have unstable medical illness. And there was a pre-post design here, preparatory psychotherapy, integration, all the things that you've sort of heard about. And what they found was decreases in depression, anxiety, fear of death. And really what they were going to do after this is do a controlled trial, but the sort of music all came to an abrupt halt, and it was over, only to sort of be resurrected in the modern era. And it's unusual for major academic institutions to work together, but we really worked hard to do this together. Charlie Grobe was my main mentor. He's the one that got me involved in psychedelic research. He completely is the one that helped our group get started. A fair amount of our protocol was designed, Charlie helped us a lot, and so did Roland. You'll see a lot of our measures were similar to the Hopkins trial. This was the UCLA trial measured by Charlie. It used a dose of 0.2 milligrams per kilogram. Everybody was terminally ill. The 0.2 is too low of a dose. It turns out that 0.3 milligrams per kilogram is more of the optimal dose. I'm going to go through this quickly because I want to get to our trial. But what Charlie was able to show that they could feasibly do the trial, it was safe, and they found a trend towards reduction of anxiety and depression. And there were no serious adverse events. There was also a trial done by Peter Gasser using LSD. It wasn't only in terminally ill cancer patients, it included those that had other major medical illnesses. So in terms of our trial, again, it took us a very long time to do this. It took 2 years to get a Schedule I license. We had almost no money to do the trial. These trials are not funded by the federal government, even though we get approval, so it was all private philanthropy. In the beginning, we got a very small grant of about $80,000 a year, which really was not a whole lot. Anyone that does research knows that is an insufficient amount of money. We got a letter from the NYU IRB a couple years into it saying, you're so far behind your accrual target, we're going to shut you down in 6 months. And that was when I turned to one of our new donors and said, we desperately need money, and he gave money, and that actually led to Gabby. Where is Gabby? There's Gabby. So you probably have heard this many times from me, Gabby. But Gabby came in and literally saved the project. Gabby was a key personnel member. We were able to get her inside the cancer center to recruit. And in the end, it really wasn't politics that would have doomed it. It really had to do with resources. So this was published on December 1st along with the Hopkins trial. It ended up being a major news story. And again, this is the only psychedelic study that's ever taken place at a dental college, which I'm very, very proud of. And my title is much more impressive. It looks more impressive than it really is. I know nothing about dentistry, but these crazy, amazing dentists, they reached out to us when Bellevue was saying there's no way you can do this here. We're not going to let you experiment on dying African-American individuals. We thought that it was over, but the dental college reached out to us. I didn't even know we had a dental school. It was really a lot of cognitive dissonance. But we walked in, and there was sort of like the head administrator was a 28-year-old person who had gone to UC Santa Cruz, and he was like, yeah, I heard Timothy Leary speak at some point, and this is really cool, and okay. And I said, you know what's a Schedule I drug? We need a big safe. And they're like, yeah, we can do that. All right. So dentistry, it was remarkable. Now, at the end of this trial, we wanted to do an alcohol trial, and they said to us, well, we don't feel comfortable with, drunk people walking around, and I said, well, it's not really like that, and they said, Bellevue has more alcoholics than any other place in the world, you should do it there. But I didn't think that we could go back to Bellevue, but time had changed, politics had changed, and we were able to relocate everything back to Bellevue, which I'm very happy and proud about because it's the exact right place. It's where there's an enormous amount of human suffering from trauma, addiction, death and dying within that hospital. So it's an amazing place to work, and I'm so glad that we can use our laboratory to apply it to the patients that are suffering in that hospital. So we recruited 29 individuals, 18 to 76. It was a 9-month trial. It was double-blind, placebo-controlled. There was a crossover at 7 weeks. It was 1 dose of psilocybin, 0.3 milligrams per kilogram, versus 1 dose of niacin in conjunction with psychotherapy. Our model was that of medication-assisted psychotherapy. There was a diet therapy team, preparation, integration. We included those that had at least 1 year life expectancy. The majority of our patients had adjustment disorders. We excluded people that had major psychiatric illness, especially psychotic spectrum illness or risk of psychosis, and all the trials essentially do that. There were 6 hours minimum of preparatory psychotherapy. We reviewed someone's history of their life in great detail. We reviewed the history of cancer and how it's negatively affected them. We prepared them for the trial, for the dosing session very carefully. We used Matt Johnson's guide from 2008 as part of that. It was a really seminal paper written by Matt. The dosing sessions, these are long days. Anyone's ever done this, you're there for 8 hours. It's a huge expenditure of energy and resources, and it's a really profound experience, both for the participants and for those that are doing it. But again, we tried to pick a bunch of psychotherapeutic models that would contain the experience, including existentially oriented treatment, psychodynamic models to understand symbolic imagery, existential therapy, cognitive behavioral therapy. There was 2 to 4 weeks of preparatory psychotherapy. We measured distress the day before and the day after. It was a crossover design, so half got psilocybin first, half got niacin first. 7 weeks later, they crossed over, and then there was 26 more weeks of post-integrative psychotherapy. We measured anxiety and depression, existential distress, quality of life, and mystical experiences. As I mentioned, it took a full year to get approval. Even though the government banned psychedelics, there was always a path towards getting approval, which is very, very laborious, but completely doable. And again, this weird pathway through dentistry. So we pre-screened 108 individuals. We ended up randomizing 31. Now, because this did not happen at Bellevue, it happened at the NYU Clinical Cancer Center, which predominantly, as you can see here, we recruited individuals who were Caucasian. About half were atheist or agnostic. The common participant was a woman in her mid-50s that had metastatic gynecologic cancer who was dying. Initially, we took people who were dying, but then we realized that you could have any stage of cancer, including being in remission, and still have a lot of anxiety. So there's nothing about dying per se that is the only way you can be anxious. Just the word cancer by itself is enough to evoke people and to be distressed. So it's really remarkable that psilocybin, when used in controlled laboratory settings, has an enormous safety profile. And we found pretty much something similar. There were non-clinical elevations in some cardiovascular measures. There was some transient anxiety. These are very difficult experiences. Our patients have usually some terrifying encounter with cancer. These are not ecstatic experiences only. They're difficult, and we encourage patients, if they have something difficult, go towards it. We support them and to sort of go into the experience. That's usually when something therapeutic happens, when they can let go. But no major psychiatric sequelae. These are the cardiovascular measures. And there have been over 2,000 doses of psilocybin administered in the last 15 years, and there really have been 0 serious adverse events attributable to psilocybin. So if you can rule out people that have major mental illness, psychosis, medical illness, and all of the careful preparation, there's a very good safety profile of using this drug. So what we found is that psilocybin acutely acted as an anxiolytic. This is the psilocybin group. Over here, this is the placebo, and you can see when they get psilocybin, there's a big reduction here in distress. You can see the placebo group has a bit of a blip, but then they go back up to their baseline here. And this is 7 weeks out. Is it 7 weeks out? No, this is 26 weeks out. So this is the crossover here. But if you look here, you can see from 1 dose of psilocybin, this is 8 months later that they have decrease in distress. This is the placebo group. When they get psilocybin, they have a big reduction in distress here. They start to look like each other at the end. So we found that psilocybin was an acute-acting anxiolytic agent, that it worked 1 day after, that it was sustained for at least 6.5 months. We also found that psilocybin was an acute-acting antidepressant agent, similar thing here, and you can see this goes out for several months. What's interesting is the only other drug in psychiatry that's an acute-acting antidepressant is ketamine, but ketamine degrades over a couple of days, does not last several months. So this was a sort of big finding in psychiatry, to have something that works right away, and we definitely need that, and then can have an enduring effect. And this went along with Robin Carhart Harris's paper using open-label psilocybin for treatment-resistant depression. And I won't go into the results of that trial, other than they did show acute-acting antidepressant effects. And I just want to mention something here about the effect size. These D values here are effect sizes, and these are Cohen's D effect sizes. It measures the difference of the magnitude between the two groups, and you can see they're all essentially over 1. For a drug to be approved as an antidepressant, it only needs about 0.3. It needs to just be a little bit different than placebo. So we saw at the end of sessions, patients felt so much better. I mean, they would say, those symptoms are gone. We bring them back the next day, I don't have those symptoms weeks later, months later. So we knew something was going on. Gabby and I kept saying, this is, I don't understand this. And then when we looked at the data, we could see that this was a large magnitude effect. And you saw this, Matt showed this earlier. I won't go into this, other than it was striking how similar the results were between NYU and Hopkins on all of the main outcome measures, secondary outcome measures, that these two trials really replicated each other with similar but slightly different designs. Now, again, what's interesting is, as I mentioned earlier, antidepressants tend to not work in cancer patients. So, and again, in this one meta-analysis, they worked about 40% of the time, about the same as placebos. And if you look here, this is response and remission rate. This is the Beck Depression Inventory. And if you look here, one day after getting psilocybin, about 80% of the individuals here meet criteria for remission from depression. And again, we don't have anything in psychiatry that could do something like that. And that's double the rates of what we saw in that placebo in the trial that I mentioned earlier, the meta-analysis. And you can see that these 80% rates endure upwards months later. And again, this is the Hopkins data. The remission rates were even higher. And these were clinician-administered measures, upwards of 90%. So if this is something that shows to be the case in phase 3, it's a very clinically meaningful thing to be able to do. We also measured existential distress. We found that psilocybin led to decreased demoralization, decreased hopelessness, increased spiritual well-being. What was interesting is we did not find an anti-death anxiety effect. This is when you sort of, patients were telling us that they felt so much better. A lot of them said, I'm not scared to die anymore. But when we looked at the data, there really was not an effect. Now, Hopkins did find an anti-death anxiety effect, and these are small samples. So it's important to understand what's going on. We did look at this death transcendence scale, which measures attitudes and cognition towards death rather than affect. And we did see some changes here, so it was kind of a mixed finding. But if we can affect death anxiety in some way, I think that'd be profound. We also improved quality of life. When we asked the participants, and again, this was directly from Hopkins, they helped us with this, but what we found is these are highly meaningful experiences. 70% of the individuals said it was the singular top 5 most meaningful experience of their lives. And we really think that these are highly instructive learning experiences, up there with having children. And we think at the level of neuroplasticity and learning that these experiences may endure for so long, because they're so profound. Now, we also measured mystical experience. We used the validated scale by Johns Hopkins, and we did a mediation analysis very similar to Hopkins. And what we found is that the intensity of the mystical experience is one of the big drivers of decrease in anxiety and depression 6 weeks later. And it's hard to understand exactly what this is. There's subscales, and the Hopkins group and our group are going to combine our data and really try to take a look at what might be going on. Gabby's going to give you more sense from the qualitative information about what may be going on that may be helping individuals feel better. Okay, so could psilocybin have anti-suicidal effects? Matt sort of hinted at it later. Somebody definitely needs to do a trial in those that are depressed and suicidal to see if psilocybin can have anti-suicidal properties, but I think that it might. Ketamine has anti-suicidal properties. There's the population-based data that we mentioned. And even though we didn't take patients who were suicidal, we affected at least 3 constructs that can improve this hastened desire for death. This is the study Matt showed earlier. So in summary, we were able to safely do this trial. We were able to recruit individuals. We found that psilocybin was both a rapidly acting anti-anxiety drug and antidepressant drug with a large magnitude of improvement compared to the placebo. The effects were sustained up to 6.5 months. 60 to 80% continued to have clinically meaningful reductions in anxiety and depression. Psilocybin induced mystical experiences compared to placebo, which was one of the big drivers of therapeutic outcome. These were very spiritually significant and salient events, and psilocybin also decreased existential distress, improved quality of life. So what's going to happen next is really interesting, and then I thought that if psilocybin is going to be approved, it's going to take like a decade or longer, but we had this historic meeting with the FDA about a month ago, and it is remarkable at the level of the FDA how much interest there is in something that can work rapidly, in something that works better than normal antidepressants do. So on December 1st, the 2 trials were published. It made the front page of the New York Times. It garnered 1.7 billion views internationally. It was one of the biggest news stories of the year. And really what made it a big impact was we had 12 commentaries from individuals, leaders in American psychiatry, European psychiatry. We had 2 former presidents of the American Psychiatric Association. So this has not come back on the fringes. This has come back within the heart of academic medicine, which I think is such a big deal about all this. So the USONA Research Institute, the Hefter Research Institute had the vision over all these years to fund these trials, but Hefter is not a drug development organization. So Bill Linton, one of our main donors at Hefter, formed USONA so that you can take a drug to market and act like a pharmaceutical company. So soon, in the next several months, there are going to be 2 major multi-center trials, most likely, that you need 2 phase 3 trials to establish a drug as a medication. And I would predict within the next 3 to 5 years, these trials will be done. And I predict that they will be positive, and I predict psilocybin will be rescheduled, which I think will profoundly change the care of those who are sick with cancer and especially dying. I'm particularly excited about the use of psilocybin in hospice settings. So very, very briefly, before I turn it over to Gabby, we've been doing this for 10 years. The first 10 years felt like we were a snail crawling along in the dark. I mean, we had to be secretive. It was very hard to get anything done. But something has changed, and there is, I think, a big inflection point, and you will see a huge explosion of psychedelic research within academia, both in the United States and in Europe and throughout the world. And one thing that we've done in 2016, we rapidly expanded our group. We've relocated to Bellevue. We have this new experimental therapeutics research laboratory. A lot of the members you've heard from this weekend, our 2 active trials are psilocybin to treat alcoholism, led by Dr. Michael Bogenschutz, our psilocybin religious professional trial, led by Tony Bossis, that you've heard about. And you can see that our group is getting bigger over time. And we have space. And Michael told you about the alcohol trial. I won't get into the details of that. Tony mentioned the religious professional trial. So we are soon going to be getting a gift of $10 million from a new donor. We're soon going to establish the first academic-based psychedelic research center. And we're going to be testing a whole host of compounds, including psilocybin, LSD, DMT, ibogaine-like compounds. We are already doing ketamine trials. We're soon going to be doing MDMA trials, etc. So we are the only site in the world that are now part of therapeutic research with psilocybin, ketamine, and MDMA. We're working with USONA. I just got 3 grants from Janssen Pharmaceuticals to study S-ketamine for treatment-resistant depression. We are now working with MAPS as a phase 3 site. It's really exciting to be working with MAPS. They have done so much amazing work. Rick Doblin is just remarkable. What he has done with the FDA. When I saw the manual for the MDMA-assisted psychotherapy, I was completely blown away. We had established a psychedelic psychotherapy training program, but when I looked at the MAPS one, I realized it was kind of Mickey Mouse version, so we had to put it away and restart. So we are addiction psychiatrists at heart, so we're going to extend our work beyond alcohol to other addictive disorders, in particular opiates. We have a huge opiate epidemic out there. We are going to be studying treatment-resistant depression, as I mentioned, PTSD. We're developing a trial using psilocybin to treat anorexia. We want to use it to treat personality disorders. We want to get into AIDS-related distress, criminal recidivism. We're also interested in care providers. Cancer is not just a disease of the individual patient. It's a family system illness. The care providers, the oncologists, everyone seems to get sick. So we want to do a trial of family members and oncologists as well. We also want to extend our psychedelic psychotherapy training program. Even though we are geared towards treating human suffering in a hospital, we now are doing things that could have a pro-social impact. We're waiting for this Templeton grant to come through. Sam and Michael are going to hear any day about that. Our new major donor is from Colombia. There's a big war that has just recently ended. The FARC and the government there have sort of made peace with each other, but there's enormous trauma there. So we want to develop a trial using MDMA and ayahuasca for conflict resolution and see if we can expand that into other intractable conflicts in the world. We are designing a trial of giving psychedelics to psychoanalysts. We think this could be the real sort of road to the unconscious. We're interested in enhancing spirituality, meditation, creativity. We are designing trials of using high-dose psilocybin for theoretical physicists, mathematicians, and also we've heard so much about microdosing, but we don't know anything about it. There's never been any controlled trial, so we're developing an LSD microdosing trial for creativity and also depression. So I just want to acknowledge all the people that give us funding, but it's really private philanthropy that funds this research. The federal government does not fund this research. We could never do it without them. It's only the generosity and vision of our donors. And with that, I wanted to thank you for your time and invite Gabby Agin Liebes to come up.
Is this the point? That's the point?
Yeah.
Hi. You guys hear me? Yeah? Great. Hi, thank you so much, everyone, for having me. And thank you, Steve, for your great presentation and for being our fearless leader all these years. So what I'm going to talk about today is... start there. What I'm going to talk about today is a qualitative study that my colleagues and I conducted, and we really wanted to understand the subjective experience of the participants in the trial that Steve just presented. So participants in our study, like Augusta, whose quote is up here, presented with significant distress, many with a sense of shrunken identities, and they described emotionally shutting down, living lives without zest and meaning, really living under the fear of cancer. And but after a single psilocybin session with supportive psychotherapy, almost all of our participants left our study with a sense of aliveness that they carried with them for weeks and months, some of them years. And they really moved from a place of traumatization to transformation. So my colleagues and I set out to elucidate the phenomenology of psilocybin-based transformational experience. We wanted to understand the subjective experience and the mechanisms of change in order to really understand why our participants were not simply recovering back to pre-cancer levels of functioning, but growing beyond it. As you can see depicted here on this graph, resilience is an attribute that refers to, is an attribute that allows a person to maintain a relatively stable state of functioning after an adverse event, but also remain relatively unchanged by that event. Growth, on the other hand, in response to a trauma or a crisis, differs in that a person is positively and significantly affected by that experience. Growth, though, as you can see by the dip in the graph, the green line, does often entail some form of psychological disintegration before one reintegrates. And as you can see here on the graph, the line goes way up beyond a level of resilience. So what we were curious to understand is what's happening in between those data points, between the disintegration and then that point of reintegration. So what I want to propose today is that the psilocybin experience provided our participants a powerful corrective experience of connection in which they were able to connect with their emotions and thoughts in a direct way, unmediated by the boundaries imposed by their sense of selves or egos. And during these sessions, participants were able to transcend their psychological identifications with their egos and sense of selves. And as a result, participants were their sense of selves in relationship to their cancers, to death, to others, to the world, and for some to everything shifted. And these experiences inspired new ways of being, which translated into enduring experiences of unity and wholeness, growth and healing. So now I'm going to describe a term, egolysis, which my colleagues at NYU have developed. And egolysis is a combination of the words ego and lysis, as you can see here. Ego refers to the psychological mechanism that maintains our conscious sense of selfhood. Lysis, which is a term that's often used in biology, refers to the rupture of a cell boundary. But when you combine these two words, we get egolysis, and so as such refers to the rupturing of an ego's perceived boundaries. So we know that the mind is capable. We know that the mind is capable of modulating its boundaries in its relationship to self and other, internal and external experience, conscious, unconscious experience. And this can arise in meditation, prayer, dreaming. We also know that psilocybin and other psychedelics can reliably catalyze these egolytic states, and which also appear to form the basis of peak or mystical experience. And so what I'm going to talk about today is the process that follows the egolytic state. And it appears that after egolysis, the mind becomes open to creating new connections with thoughts, feelings, and sensations. So I'm proposing that these corrective connections are the vehicle of post-psilocybin growth. So just a quick note about our methods for our study. We interviewed a subset of the 31 participants, or 29 participants rather, that ended up completing the study. So 13 out of the total 29. And we asked them questions regarding what their lives were like before they came to our study, what their experiences were like during the psilocybin session itself, and then also what their lives were like after the experience and the study. And in order to assure fidelity and consistency across our raters in our study, we had cross-checking and used auditing. And the method that we used was called Interprete Phenomenological Analysis, or otherwise known as IPA. And we picked IPA because we felt like it was a good fit with our goals. And IPA is committed to maintaining the authenticity of a participant's experience, while also recognizing that sometimes people struggle to express what they're experiencing and feeling. So to a certain degree, the researcher, has to interpret what that person is saying. And especially with psilocybin and other psychedelic experience, it can be really hard to talk about what's being experienced. Sorry, excuse me. So, sorry about that, guys. Oh yeah, that would be helpful. Thank you. We also were committed to. Is that better? There we go. We also were committed to the phenomenological approach because we believe that it can substantially contribute to cross-disciplinary conversations and really trying to understand these phenomena. And it can help to sort of prevent the battles that might take place over terminology, which can impede progress rather than fostering sort of our understanding of these phenomena. So the phenomenology of anxiety teaches us that when we feel that our survival is somehow threatened, we are instinctually driven to flee or fight that experience. In speaking with our participants, we learned that the emotional, sorry guys. In speaking with participants, we learned that the emotional traumas they experience drove them to guard against new experiences that they might perceive to be threatening, in effect strengthening the walls of their egos. They reported dissociation, fragmentation, and avoidance of new experiences. And as you can see here, Mike was coping by running. I was in constant motion. For Brenda, she explained that I was not really living. So while adaptive in the short term, these strategies and state of being ultimately limited their ability to live fully and authentically. So back to this graph. Nearly all of our participants reported that the immersive nature and effects of the psilocybin experience were very effective at triggering egolysis and loosening their defenses and sense of control. For some, this was felt as scary and challenging, especially at the beginning of the stages of the session. However, psilocybin, we believe, is therapeutic because it has the capacity to break through the subjective walls of the ego. And despite feeling disorienting, most participants said that once they moved through the difficult experience, the opportunity for corrective connection arose, and there was a positive phenomenological shift. And I do want to remind everyone, as Steve mentioned, that everyone in our study was in an incredibly controlled environment. And because these experiences can provoke overwhelming feelings, it is really important to have a container that is supportive of integration and these corrective connections I'm speaking about afterward. So these kinds of changes often don't arise through reason or logic. They often require a new experience to counteract the old ones and to begin reinforcing new connections and pathways. And psilocybin-mediated therapies is an experiential approach. This is important to emphasize. And learning is not gained simply through increased insight, but through new living, new being. In this form of new being, participants experience life without ego labeling. And I'm going to read this quote right now. Let me put my glasses on. So Mike said, during his psilocybin experience, I reached out and started bringing in all these shadows and fears that we all strangle ourselves with. What had been an impermeable membrane was now no longer impermeable, and these barriers broke down. I was gathering in the debris of this chaos. The chaos was now something I could work with. And all the anxieties and fears that I have, there's nothing to them. They can't stand the heat of my attention. So here we see that Mike's merging with his fear in a non-dual way. And in doing so, he let go of the stories, the commentary, the judgments that he had about it. He could be with his fear, accepting the experience itself, and leading to the realization that the fear had no substance. We also see here that it's not the struggle per se that causes distress, but the intense struggle to escape it. So next I'm going to discuss some components that I believe are part of this growth process. And I'm going to start with the felt sense. So I described earlier that the ego functions to create self-defined labels. But what happens if you don't label things? Then you experience things as if you were experiencing or feeling it for the first time. And there's no sense of separateness between you and the experience. It's beyond intellectual description, as Erin says here. It was a feeling to the bottom of my core. And the felt sense process provides powerful access to inner knowledge and relays important integrative information to the psyche. Next component's mindfulness. As many of you know, mindfulness refers to non-judgmentally being aware of whatever is arising. It also involves becoming aware of the ego's labels and also accepting the reality of each moment. With acceptance of the situations that were driving their fears, our participants found that they could let go of the perceived need to avoid or escape these realities. They could relax into awareness and into presence. And Adam here describes during his session, and here he's speaking about his lymph nodes which had cancer in them. He says here, I saw my lumps on a black background, and I could see through them. And I realized these lumps, you should accept them. They are a part of you. The next dimension is metacognition, which is also often referred to as a construct of mindfulness, and refers to being aware of awareness, essentially. And it allows a person to approach your experience with a sort of detached engagement. And it allows her to view negativities as passing events rather than abiding realities. And in this quote, I won't read it all, but Adam, he's basically seeing himself outside, from the outside, and realizing that anxiety is coming up internally. But through the sort of metacognitive distance that he's able to sort of create, he realizes this anxiety is only real because he's letting it become real. And participants reported experience expanded senses of identity through the process of interconnectedness. And this corrective connection manifests as a movement from a me identity to a we, from that of a separate bound identity to a vaster identity, which could hold their experience with a greater sense of security and belonging. In this way, they became securely attached in the world, in the universe. And Aaron here says, it's a relief when you think you're separate and you think you have to do everything on your own. And then you realize that it's not, and you're a part of something. We're all connected. So you may have seen this image, I think, is posted all over the place here. But I really think it speaks nicely. I'll get to this in a second. But growth occurs when a person moves toward greater freedom in response to reality as it unfolds from one moment to the next. One is able to respond to each experience freshly, unencumbered by reinforced patterns of action and perception. Cancer, trauma, pain can be recognized without letting it define her. This liberation involves a movement toward a new plane of existence with a radically different perspective and foundation of experience. The corrective connection experience allows for increased complexity and flexibility, as evidenced by the data I've shared with you today and these brain maps, imaging maps of the brain behind me. As you'll see on the right, the brain under the influence of psilocybin is much more open and exhibits freer communication between all networks of the brain, as opposed to the brain on the left, which is a placebo brain or a brain under sort of normative state of consciousness. And in this brain, communication is really confined to particular clicks, such as sort of auditory to auditory. It's not connections with sort of new networks in the brain. So what I believe is that the corrective connections catalyzed by the psilocybin egolytic process inspires relational shifts with oneself, with one's mind, with others, and the world, so that you can create new states of information flow that are no longer rigid but permeable. I end by offering you a metaphor. Instead of a wall guarding the ego that is characteristically inflexible and defensive, corrective connections through egolysis transmute this wall into a net. This net is protective but porous. It gives it shape and structure, but it's also flexible. And this net is dynamic. It can accept new connections and change shape. The net is stronger than a firm barrier. Its identity more mature and more secure. Importantly, this net allows one to feel her way into new realms and a myriad of potential pathways forward. And that's here are my acknowledgments to my wonderful colleagues and our Courageous Study participants. And I want to thank you so much for your presence. Thank you.
Thank you, Gabby. Thank you very much, and Steve, too. So we have some time for questions. Line up here. Sir, what's your first name?
Hi, Ben Sessa. I'm a addiction psychiatrist in the UK. A question for Steve, just picking your brain about addictions. I'm just about to start an MDMA-assisted psychotherapy study to treat alcoholism. And given that I know the work of Johnson and Bogenschutz and Krupitsky and all the way back to Osmond, that the most powerful abstinence came from the mystical and spiritual experience, do you think my study with MDMA is going to work?
Mm-hmm. Well, I think if you take alcoholics that have comorbid PTSD, and I think if you're thinking that their alcohol use is related as a form of self-medication to their untreated PTSD symptoms, then I would think MDMA, by indirectly affecting PTSD symptoms, could make the drinking better. If you go under the assumption they're using MDMA just to treat alcoholism and you're using the model of inducing a mystical experience. I think MDMA is much less likely to induce that kind of experience. But I think it's definitely an interesting idea and definitely worth trying. So thank you for doing that.
Hi, I'm Jessica, and I want to refer back to when you were talking about that there was no reduction in death anxiety, and you also mentioned existential therapy. And I was wondering if there was any attempt in therapy to connect the existentialism's view of anxiety as a tool and kind of reframing their anxiety as something that could manifest energy towards maybe making amends or, saying goodbye or, for those people who are actually going to die.
Want to answer that?
Yeah. So I just want to make sure I understand your question precisely. So you're wondering if if maybe the death anxiety was sort of sublimated into a different sort of manifested in different ways. Is that what you're saying?
Well, I'm wondering if, as a therapist, was there any attempt of kind of helping the clients reframe that for themselves?
To reframe their
Anxiety into something that is a tool.
to anxiety that's
Yeah,
Well,
as opposed to reducing it, kind of making it a meaningful tool is what I'm saying, yeah.
We help patients
Yeah.
sort of go into anxiety. So a lot of times during sessions, patients would have this horrible, overwhelming anxiety, and they knew ahead of time that they should sort of like dive into it and go into it rather than run away from it. So that was a common thing. In terms of existential distress, we did find a whole host of measures that showed decreased existential distress. So overall existential distress was down. Even though our death anxiety scale didn't measure a decrease in death anxiety, we did have improved attitudes towards death. So I think when we design the phase 3 trial, we really need to look closely at how to use psychotherapy in conjunction with the experience to go after these particular types of anxieties in various ways. But there's a lot more room to be done to perfect something like that.
Just to add, in the qualitative study, we did, I would say like 9 out of 13 participants described having a death experience. So it may be that we're not measuring it correctly, that the outcome measures that are being used are not capturing the phenomenon.
Thank you.
As well, yeah.
Hi, my name is Mark Caspero. I'm a psychiatrist in practice in Santa Cruz, and I've been using ketamine to treat depression and PTSD. And contrary to the NIMH protocols, I'm finding that high-dose sessions seem to have much more therapeutic value. And particularly, the context that I've been working with is to create a kind of a rationale where people can understand a sense of identity beyond form. And I'm wondering, in your work with ketamine, are you doing anything to kind of prepare people, to give people a context, a way of understanding of what lies beyond when we think we're something?
Yeah, we're trying to trend more towards Evgeny Krupitsky's ketamine psychedelic therapy, but the NIMH model is a biological psychiatry model. It has nothing to do with experience. It's NMDA antagonism, AMPA throughput, etc. And Janssen Pharmaceutical that's developing S-ketamine knows, pays no attention to the subjective experience, a completely biological model. The trial that I did at Bellevue Hospital in NYU, we did IV ketamine in the emergency department, and they really didn't get it. I said, oh, we need a nice room. No, you put a curtain around them and you just inject. So now the S-ketamine trial, we're going to be doing it in our psilocybin room. So when we do the intranasal, we're going to try to have them focus internally. So our model definitely is that the subjective experience makes all the difference, and we'd like to move in that direction. But the makers of ketamine and the researchers there don't think that way, but they ought to.
Thank you. Thank you very much. Please help me thank Stephen Ross and Gabby Agin Liebes from NYU program. Thank you so much.